अस्सलाम वालेकुम। जो लोग मौजूद नहीं हैं, obviously उनके लिए तो कुछ नहीं. जो लोग मौजूद हैं, I'm grateful that you guys woke up this morning and turned up. Although the idea of finishing last night early was that you get good night's sleep and come early, but it happens. We're used to this. Like, we must change this culture in Pakistan society. This is a routine. We must fix this. Obviously, we know all what COVID did to the world. And basically, the idea was that if you're going to be doing some kind of nose surgery, the COVID virus resides there and it can cause serious problems because it's viable for hours in aerosol. And if you're drilling in that area and you're using cautery, you can cause these to spread. So the first COVID-19 patient who underwent transphenoidal surgery was in China. And the claim was that it infected 14 doctors and paramedical staff at that time. That was the claim. But several medical staff outside the operating room were diagnosed with COVID, while ones who were in surgery, none of them got infected. So the guy who was the main surgeon, he wrote in an article later on telling us that all the infection was on the person who was transporting the patient, the person who shifted the patient, the nurse who was there on the ward, the guy who dealt with putting an IV line, etc. They all got infected except for people in theater who were wearing ordinary masks and ordinary gloves. So protection question is that really, does it matter that you're operating or not? We really don't know. Then there were studies from Stanford confirming that there were higher risk if you're doing pituitary surgery. So initial recommendations from all over the world were that you're not going to be performing transphenoidal surgeries on all elective cases. Only emergency cases, and even those you have to think a couple of times, because at that time it was shown that 1 in 3 patients who will get an anesthesia will develop some chest problems. And if you have a COVID patient with chest problem, I'm sure all of you have seen a CT scan of a COVID patient and you know what it looks like on the chest. So the guidelines came in from all over the world. Actually, Pakistan Society of Neurosurgeons also came up with their guidelines, and they were on our website and have been on our website for some time. And all elective transphenoidal surgeries were postponed at that time for 3 months, actually. But the crisis, when it became never-ending, some surgeons started doing transcranial surgery for it, which I wasn't sure was the right way to go. You could have probably waited a little while. So all patients who were screened, if there was history of travel, fever, breathing difficulties, and PCR was done. Question is 1 or 2. So the guidelines were that within 48 hours, you need to have 2 COVID negative before you do that. This is at that time. Operation theater layout, obviously laminar flow was recommended, minimum traffic in theater, and send everyone out of theater except one anesthetist who was intubating at that time. Obviously, this intubation box came in to reduce the risk of infection to the anesthetist. Staff were educated in some way, and all the unnecessary tools and equipments were removed. Endoscopic tower, etc., were draped. Patient's face, mouth, and nostril were draped with an additional layer of transparent steady drape. So we used pyridine in all our patients in the nasal cavity, although it's an irritant, but we were able to soak it. And the idea was that we didn't want the COVID to spread if it was there, if there was small risk there at any time. So pituitary tumors itself, patients are at a risk of anesthesia, and this is because of having hormonal difficulties. So there are some people who use this kind of protective mechanism in which they draped and paint just like we always do, but then what we do is we cleaned inside through this area, but the problem was the aerosol was still spreading, so it was all theoretical. Somebody used this glove-like thing, made a small hole in the patient face mask and put in a finger cut out from a glove inside and used that. Again, there were risks involved. It only worked experimentally, but it wasn't able to protect the aerosol. So what we did was we had patients whose vision were deteriorating and patients with apoplexy, large tumors. So we used an existing microscope transparent cover. We cut it open wide, wrapped it around patients, creating a collapsible tent, and all equipment and instruments were kept inside this tent. The objective was that we reduced aerosol and contain it inside a plastic cover. We did 11 patients during the COVID period with no complications during these time. Did have some difficulty in maneuverability, and it's normal because you're trying to pull the thing up, and I'll just show you in the video. So it was something like this. This was draped all around, and everything was kept inside, and we worked underneath. So all the equipment that we were using was used inside. We did not use a cautery, did not use a drill during this time. This is the routine pituitary theater design that we have, and that's what we generally use, and we continue to use the same way. Except for what we did was that we're using this stent, and there's this plastic sheet, as you can see, is shown here. So after intubation, once the patient was intubated, we at that time were taking 15 minutes break. And the idea was that the aerosol might have come out during that time. And so only one team member was allowed to stay inside. All personnel were given gown, gloves, eye cover, respirators, N95. So whatever they wanted, they had that option. Additionally, as I said, we used povidone-soaked gauze inside. And patients are completely wrapped in this modified plastic. It was obviously time consuming. The initial couple of plastic drapes obviously wasted as well as we were trying to make them. But obviously the increased cost was always minimal because just that microscope cover is the minimal thing. The only thing was maneuverability was really tough in some cases. I'll just show a video, and basically the idea was this was for safety of patients, safety of OT staff, achieving the goals of surgery, minimizing the risk, and awareness of the difficulties that are involved with it. All right, so this is just a video showing how it was put in. And you put in your hand, we made holes. Can we continue to run this, please? Yeah. So you put in small holes for the three people who were around, the assistant, the surgeon, and the anesthetist, and they were able to manipulate things inside. So one side was this, the things were all inserted from one side and then closed and sealed. And then that's how it was done. So it was just one of the innovations we did. And of the surgeries we did, obviously the time increased during surgery. Otherwise, everything was straightforward for us. Thank you.